on. So take it away.
Thank you so much, Carl. That sounds great. And before I get my screen up to share it, I just want to thank you all for being here and for inviting me, and say how inspired we are in Georgia. I'm one of the members of Georgia Clinicians for Climate Action too. And you guys have just really hit the ground running up there in New Hampshire and are doing so much that we are just watching and finding inspiration from as well. So thanks for being here. I hope to learn from you all as a part of this presentation too. All right, getting my screen shared here. And so does that look okay, you guys?
It's great.
Looks great. And so as Carl mentioned, I have a lot of hats. I focus on climate change really for my research and scholarship. I did environmental health work and have a master's in environmental science and policy. Did all that before coming back to medical school, and now have been able to work on those things together. So I teach students and residents about climate change and look at how climate change harms child health and things we can do about it, both locally and globally. I wanted to ground this for a moment, just with a slide on the global picture. This is a map that I use a lot in presentations. It's old now, it's from 2007, but I haven't really found anything that shows this better. So this is from Jonathan Patz, and the top map is showing relative contribution to global CO2 emissions. And you can see this, the size of the country shows the amount of CO2 emissions. The US is disproportionately large, kind of bloated looking there. And the bottom map shows the projected mortality up to 2030 from just 4 climate sensitive diseases, and that's inland and coastal flooding, malnutrition, diarrheal disease, and malaria. You can see that these maps are the exact opposite. This really hones in on the fact that this is a profound issue of intergenerational justice and social justice here. Those who have contributed the least to the problem are affected the most. I think that's why a lot of us are in this space. And yet this very map can feel a little bit overwhelming when we're busy. We spend our lives in clinic and clinical care. So how do we bridge these worlds, and how do we be a part of the solution to this problem of social injustice in our day-to-day work? That's what I hope we'll talk about today. I think it's also important to realize that that map that we just saw is reflected many times over on a local scale too, where we have profound issues of structural racism that are also embedded in how communities will feel climate impacts. And the slide I just showed and this slide are part of lectures that I give now the first couple of weeks of med school to all of our new med students, to really show that this question of climate change is a question of social justice. So you all are, I'm sure, familiar with the policy of redlining, this federal housing policy of the 1930s that systematically diverted investment away from communities of color while initiating less desirable landfill projects, highways, infrastructure in these same areas. And the map on the left shows Richmond, but there are many maps in many different communities. This paper referenced at the bottom there by Jeremy Hoffman was really a landmark paper in this area, and showed how former redlining relates directly to disproportionate exposure to those extreme weather patterns, extreme heat that'll be worsened by climate change. So they mapped temperature, land surface, and health indicators in historical redlining in 108 US cities, and found that 94% of the formerly redlined areas were hotter than surrounding neighborhoods. The temperatures were up to 7 degrees hotter in those areas, and nationally they were 2.6 degrees hotter. So they said, okay, but we can see that the land is hotter. Is that equating to worse health outcomes or a disproportionate burden of poor health outcomes? And they saw that yes, it is. So there was an increased proportion of emergency medical calls and hospital visits for heat-related illness from those same areas on extremely hot days. This led them to conclude that historical housing policies may in fact be directly responsible for disproportionate exposure to current heat events. So we have this global problem. We have these manifestations of local injustice, and how do we as pediatricians and clinicians help dismantle these? I think we first have to teach about them, right? If we don't learn about them, how will we be able to be part of dismantling them? And then we can see that what we do in our clinical setting does matter for this. So this is a patient where we're going to kind of walk through this example. This is another slide that a case that we work on the first couple of weeks of med school with students. And I want you to think about this case and think about how this relates to what we do in our practice and climate change. So an 8-year-old presents to your clinic with shortness of breath and wheezing in August. You review his chart. He has a history of asthma. He's had 3 emergency room visits in 2 months for similar complaints. You see words like non-compliant and prior notes. What do we need to do for this child? And I think all of us who have gone through training, we know what to do for childhood asthma. In fact, in a lot of emergency rooms or clinics, the child doesn't even see the doctor before they get put on something called an asthma pathway, where they're triaged and starting to get albuterol and treatment before even seeing the doctor. But all of the things that we can do inside the exam room for this child don't do a bit of good if we don't fix the things that are triggering his asthma and those exposures outside of the exam room setting. So this is kind of how I hope that our current generation of students will think of medicine. They come to medicine excited to engage with these bigger picture issues and to care for whole people. And we need them to learn all the details of medicine. We need doctors and nurses who are very good at taking care of those patients right in front of them in the hospital setting, in the ICU setting, who are very sick. Of course, we need that. But we also need to engage more with the big picture. And that's what we're going to talk about today, how we assess for environmental determinants of health, those things that affect patient health and wellness the 99% of their time that they're not with us in the exam room, how we can talk to them about exposures, including climate-related exposures, how we can think about their medicines and how we maybe need to alter their medications in warmer weather, how we need to know the bigger picture services in our community. And while I do think it's important for us to engage with this in the clinic setting, I don't mean to suggest that that is the only answer. I think by engaging in the clinic, we can also see avenues for big picture change, like a lot of what you guys are doing there too. So previously, this is kind of like how we thought we would learn in medicine: see one, do one, teach one. That one-way street doesn't really hold up for climate change, which is exciting. When I taught the first years, this past cohort coming through in August, I asked them when they started learning about climate change and health, so not just climate change. And a few of them already have advanced degrees in this topic. Some of them raised their hand or they learned about this in elementary school. Many more learned about it in middle school. Over half learned about climate and health in high school. And so this is really flipping medical education on its head. Those physicians coming through training now sometimes will know more about it than those of us who went through all of our training without any mention of climate and health at all in every single class we ever took, even as it's now been called the greatest health challenge of our time. So this is exciting, but this mantra, see one, do one, teach one, doesn't really hold up. It's kind of like we need to continue to learn, we need to continue to do, and we need to continue to teach. And we may be doing all of those at the same time. Even though we have this huge evidence base on climate and health, how we implement that and how we translate that evidence base at a population level into best practices in the clinical setting is going to continue to grow and become more well-informed over time. So our learning here is not going to stop. We're going to have to keep learning, and that learning can have ripple effects to our outer community too. So this is what I'd say is how we can get started here in the clinical setting. We need to acknowledge the value of time. We need to update our knowledge base and practice, partner with students and residents if you teach, and then just start tomorrow. Start wherever you are. Don't worry that you're not ready, just start. And for the value of time here, what I mean by that is we know that there's urgency in the climate crisis. IPCC has said we need to reduce emissions by 45% below 2010 levels by 2030 and be a net zero planet by 2050. We feel that. Once you start learning about climate change, you cannot help but not feel that. And yet every day we're measured by a stopwatch, whether it's time that's too tightly packed in the curriculum or the 15 minutes we have for a well visit, we feel that stopwatch too. And too often that wins out over the bigger picture, but it doesn't need to. And the way we can relieve that dissonance, this tension between these, and rebalance the scales is by integrating this into our daily practice. We also need to start learning and updating our knowledge base and practice depending on where we all are. And this is going to be continued part of our lifelong learning that all of us as healthcare providers know well. So there's many tools out there, and I kind of just jumped right in today. I'm assuming you guys all have some basic background on climate and health, and there's so much out there that we will all continue to learn together. I really like this interactive tool from the New England Journal from 2019. There's the Lancet Countdown on Climate and Health as well, which is a great resource. There's a lot out there to learn from. This one goes through healthcare delivery impacts as well. And I think part of that learning is having a framework that you keep in mind for assessing who's at risk. And I kind of think of it this way: who's at greater risk of exposure to climate effects? Who's more vulnerable physiologically if they are exposed? And that includes all children because they're still growing and developing. And what is an individual's or community's adaptive capacity to buffer against exposure? This is one framework to kind of keep in mind as you're assessing environmental determinants of health in the clinic so that you can address them, and as we're advocating. So all children are more at risk, but there are other populations that are also at greater risk, and some of them aren't super intuitive, like high school athletes definitely at greater risk of heat illness and actually death from extreme heat. Also a young and healthy population that we may not otherwise, without knowing this, prioritize in our anticipatory guidance. Individuals who've had recent surgery, if there's a climate extreme weather event, complications are rare, but if there is a complication, they're not able to get back to care because of the care system is disrupted from extreme weather. Those individuals are at greater risk. So we need to be thinking about these in our practice. And partnering with students and residents, I mentioned how fun this space is to work on because sometimes our students have more of a foundation in this than we do. And we can really learn from them, even as we're teaching them clinical practice, which they may not know yet, right? So we're providing that side, they may be providing some of that environmental science side. And this is a paper I wanted to reference that I worked on with Ari Bernstein and others. I know Ari talked to you all a few weeks ago that links climate change to core competencies for graduate medical education, the ACGME core competencies. And this is the framework that our learners are starting to learn from as they move forward in their careers. So we really have this moment where we're all learning together in undergrad med ed and graduate med ed, and those of us who are learning in continuing medical education as well. We're going to have to adapt as we go because that learning level is going to become more and more advanced over time. And this is the issue that the paper that I'm talking about today was in current problems in pediatric and adolescent healthcare. And I circled here all of the students and residents who were part of that issue. Brendan Gray is a third-year medical student now and is MPH here at Emory. Raisa Uden was one of my recent residents in pediatrics at Emory. All of the authors at the bottom, there are medical students. And I think part of what we can do across this space is elevate the voice of our students who are youth and who care passionately about this because they see that it is going to affect their careers going forward. So starting where you are, this is where we're really going to kind of dive in here and see how this works in the flow of our day-to-day in clinic. So I work in an outpatient pediatric primary care setting. And one of the things that this paper that we're talking about today tried to do is say, if you're a general pediatrician, how can you bring climate change into your practice and make that work so it doesn't feel like an extra thing, but feels like it's essential to what you're already doing. So this is a figure from the paper, and this is what we'll talk through. When a patient comes to my practice, one of the first things that happens is they're given screeners. We used to do social determinants of health screening. I think many are familiar with that concept, but they're climate screenings and environmental determinants of health screening that are just one more step of that same process. We talk about health promotion at every well visit. That's like bread and butter pediatrics, like what's your nutrition, exercise, these kinds of things. We want to have a system where all children, including children and youth with special health care needs, have their needs addressed. Our anticipatory guidance can be informed by climate change. One of the lectures I give to our residents goes through Bright Futures, which is the framework that pediatrics uses for anticipatory guidance in primary care. And we just highlight all of those touch points where we could link climate anticipatory guidance to what's already recommended by Bright Futures. And then we need to make sure that we know our community resource network. I think the bottom line here is in primary care, if we're not looking for climate health exposure risk and climate health impacts in our patients, we really won't see them. By looking for them, though, we will start to see them. This hit home for me recently. I learned that about 1 in 3 families in the Southeast is energy insecure. And I work in this space and have for more than a decade now, and I didn't realize that until a little bit over a year ago. I started asking patients in my clinic if they've had trouble paying their utility bills, their energy bills, and found that that is absolutely the case. And so I think it's really, we need to ask, we need to assess to be able to address the concerns our patients face and elevate them in our advocacy too. So screening, including environmental determinants of health, what does that mean? So I just talked about energy security. We ask patients what water source they use. Historically, that's been to see if their water source contains fluoride. Do they need fluoride supplements? But we can also talk about it as it relates to water safety and security and climate change. We screen for housing concerns, and if patients are unhoused, we can also use that touch point to talk on things that are climate sensitive, like mold and mildew concerns. Have they had trouble paying their energy bills? At all of our well visits in pediatrics for babies from 0 to 6 months old, we do a maternal depression screen. And this is something I know Dr. Barkin will talk about next week too. We also start screening at age 11 for depression screen in our adolescents. Climate is a big climate anxiety and displacement due to extreme weather events are big risk factors for depression. And this is something that we can start asking our patients about through these routine screenings. And then asking about access to green space as well. This is another shot from the paper, and this is an incredibly busy and dense table, but I wanted to show it once just to show that for each of the sections I'm talking about today, that this table kind of talks through what this looks like. So for food security, that top one, it talks through what the climate health rationale is there, that climate change puts crop yields at risk. In fact, per the Lancet Countdown, the 4 major crops tracked have all had decreased yields due to extreme weather events over the last couple of years. Disrupts global food supply chain, may increase the number of patients facing food security. And then we go through a question that you could ask your patients. Some of these are based on existing social determinants of health screeners. And then we talk about resources, like how you would refer these patients to services. If we are screening, we need to have a way to address them. And then switching over for health promotion. So nutrition, diet. This is something we really talk about at every visit, and it is a huge question when it comes to climate and health. There's a book called Project Drawdown that ranks the climate solutions that we already have in order about what's the most powerful towards addressing and reversing climate change. And numbers 3 and 4 on that list are reducing food waste and eating more plant-forward diets. These are really powerful tools. And that's the great news, is that we talk about food for every well visit in pediatrics. So that's an opportunity there to discuss this with patients. This Food Planet Health, this report from the Commission on Food and the Anthropocene, the Eat Lancet Commission, is something I would refer you all to. It talks about diets that optimally support human health and are within planetary boundaries. And so how close are we to that planetary diet? We kind of orient to the map in the middle and follow North America all the way up to the top right there. You see that we the circle is where that optimal diet would be. And you can see how far away from that we are. On the far left side, you'll see the global boundary there and how far away we are from this diet. So this is an area where this will, I imagine, will have continued evolution of our guidance, but in practice, I link it right back to the health of the child in front of me. And if we have a child who is eating only kind of the processed fast food or eating only meat-based sources, it is okay to say, actually, beef is labeled a probable carcinogen by the WHO about 5 years ago. Eating less meat is good for your individual health, and it is good for the planet's health too. It's also something that I realized a lot of my patients are veering away from cow's milk anyway. This used to be something that reflexively I and my partners would say, cow's milk is important, right? It has calcium, it has vitamin D. It's not the same as almond milk or coconut milk, which is nut juice. But perhaps we need to do a better job of meeting our patients where they are, asking them, why are you not drinking cow's milk? Are you thinking about a more plant-forward diet? And then letting them know that, okay, well, let's talk about calcium and vitamin D. The message isn't that you have to have milk. You just have to have calcium and vitamin D, right? So by breaking it down to what the nutrients are that our patients need, it's a little bit more effective way to do our nutritional counseling. Right now, there is not a consensus statement on more plant-forward diets for children from the AAP, but that is something that we're actually working on. What are the personal and planetary benefits of plant-forward diets for children? And hopefully we'll be able to get that out before too long. Here are some other kind of options for how we can, once we update our guidelines with the evidence base with what we have, we can mirror these in our WIC programs and our school food programs. We can think about strengthening our partnerships with nutritionists and better informing patients, and then support some of the programs out there that enable access to healthy foods through local farmers markets programs. And then actually Bright Futures and health promotion includes kind of assessing extracurricular activities for students and our patients too. I think this is one way where we've seen that engagement and advocacy can alleviate some of the mental health burden that we feel and that our patients feel. So I think of it no longer as advocating for our patients, but advocating with them. And it is okay to talk to patients about what their extracurriculars are. If you have a patient who is experiencing climate anxiety, know about the local youth groups in your area and see if it's something that they want to get involved with. Those are just a couple of the examples of health promotion. If we move on to children and youth with special healthcare needs who are there for specific visit types, you guys may recognize the sports physical form. Every child who participates in sports comes to their pediatrician to have this filled out pretty much annually. This is a place where we can talk about reducing risk of heat exposure. And this is something I was incredibly worried about this past year when our kids have been out of sports participation for more than a year, a lot of them because of COVID. And when preseason was going back in this late summer in Atlanta, where it's incredibly hot, there is a greater risk of heat illness in children who are deconditioned and adults who are deconditioned. When we fill out sports physicals, we have an opportunity to advise our patients on how to stay safe. And that means knowing what the local guidance is for New Hampshire. What are the guidelines for high school programs in terms of when they're supposed to pause practices? In Georgia, it's kind of graded. So over a certain temperature, you can't have your full gear on. And then over a higher temperature, you just can't practice at all. We need to know that. And we can advise our children who are participating in less formal sports to hydrate frequently. They need to take frequent breaks, that kind of thing. So we actually borrowed, we were talking about borrowing things from within the CCAs. We borrowed this from Virginia Clinicians for Climate Action. It was just a really well done trifold brochure. This is the back side of it. The front side talks about climate change in Georgia, and the backside talks about recognizing, preventing, and treating heat illness. And this is something that we distributed throughout our school-based health center networks and in our primary care centers throughout the state. So I know that if this is something you all would be interested in New Hampshire, I'm sure the Virginia folks would be willing to share as well. The front side does have the logos and a little bit of state specific information. The back side really doesn't need too much editing, and we had it available in English and Spanish to help educate our patients and families. We can also update our guidance. So if we think back to on asthma, if we think back to the patient scenario that we talked about, for those of you who give asthma action plans out, which is something, again, we do for every patient who has asthma in primary care clinic or if they're admitted to the hospital, we give an asthma action plan. How many of you have included air pollution as an asthma trigger or pollen as an asthma trigger? Yet we know that that is something that does trigger pollen. In fact, we know that air pollution reduces FEV1. It reduces the total volume of air that a child's lung can hold and reduces the growth in lung function over time. And we know that certain groups, because of structural racism, have disproportionate exposure to air pollution. This is something that we can include in our asthma action plans and talk to patients about. It's a lot easier to do this now, actually, because most of our weather apps include the air quality index on them. So I work in a clinic that serves almost exclusively Medicaid patients and children who are uninsured. And they still all have smartphones. Our parents will have smartphones. I'll pull up their weather app for them, with them, and we'll kind of look at how to see the air quality index on their weather app. And what does that mean? Can they change the air quality index? No, but they can be aware of it. It can lead to more proactive asthma management. And we can say things like, look, if the air quality index is in this orange range, this means it's probably not a time for your child to be outside playing. Can we think about how to get your child exercise earlier in the morning when the air quality tends to be better? Guidance like that. And then looking at the pollen count too, if you have a place that has pollen count, for those children for whom pollen is a trigger for their asthma is also important. It can give us a way to have more proactive management of asthma in kids. And then for all kids, but especially children whose life depends on technology, like peritoneal dialysis or a ventilator, or whose life depends on a daily dose of any medication, we need to be talking about disaster preparedness with them in the case of extreme weather events. I found this from New Hampshire, actually, there on the left, that there's some amazing resources right there that you guys already have. They're US-wide resources too, from FEMA, from Ready Wrigley is this little superhero dog that CDC has that has some books and other like coloring books and other resources geared towards children to talk about disasters. But this is something that in the pediatrician's office we can talk to for parents, and especially for children and youth with special healthcare needs. And getting kind of towards these last two things, informing our anticipatory guidance by climate change. This is a different article. I wanted to include something that's more geared towards adults for the non-pediatricians among us. And this is talking about just talking points, climate messaging script example from Emily Sine and Mona Safferty and others who you all may be familiar with, around how we can talk to patients about climate change and actually mention climate change as we're talking to them. Some of it is that as pediatricians, as clinicians, as healthcare providers, some of what we do actually increases the risk our patients face. So on the left there is just a partial table of medicines that increase the risk for heat illness because they alter heat and water homeostasis. And some of our medicines actually need to be stored at room temperature. So if our patients are getting mail order, which we saw a lot more of in COVID, and they're sitting out on the front porch, they need to be aware of this. I mentioned that my son has asthma, and this is just his package insert from his albuterol. I didn't realize this either, is that the albuterol inhaler doesn't deliver as much of a dose of medicine at high temperatures, and it actually has a package alert that it may explode at temperatures above 120 degrees. So if you think about, we're not talking about ambient temperatures of that degree, but think about your car parked outside in the sun. That inside of that car can definitely get to that point. So this is another point to talk to our patients about not storing medicines in in cars and being aware of what the storage requirements are for all of our medicines. Looking briefly here at other climate-related stresses that we can alert our patients to, there's something called combined sewer systems, and there are a lot of those up in New Hampshire, as I saw from this map. And what happens when we have flooding events, these can overflow and contaminate our drinking water. It's not just the combined sewer systems, it's other outdated infrastructure that put us at risk for contaminated drinking water too. This is from CDC's BRACE program, actually looking at North Carolina, but the principle is the same elsewhere, including New Hampshire as well. So what does this mean in practice? It means that we need to talk to our patients. Do they know how to access boil water advisory alerts? Are they receiving these? We've had boil water alerts in our clinic area, and patients have been using the tap water to make formula in the middle of a boil water advisory. So I think this is something that New Hampshire has a great website where you can sign up. This is something that could be included in the after visit summary for patients. Make sure that you're receiving public health alerts. This goes for boil water advisories, for things like tornado alerts, whatever those extreme weather events are. This is something that we can talk to about our patients right there in the clinic. And then finally, making sure we know kind of what the landscape of services in our community looks like. This is talking about the low income home energy assistance program, which is a great resource and is something I can refer my patients to who screen positive for energy insecurity. And hopefully we'll see some more investment in that as we move forward. And then Double Up Food Bucks is a program that is in about 25 states now, including in Georgia, where our patients can get double value for their food stamps at local farmers markets. These are just some of the kind of community systems that we can tap into, make sure that we know about so that we can help our patients access them. The other thing that's been really key is having interactions with our social workers and with our medical legal partnerships so that we know when we can write letters for patients and say, this patient really shouldn't be in an occupation where they're exposed to extreme heat. This patient, it's not safe for you to turn off their utilities right now because there's an infant in the home or there's a pregnant mom in the home because of the risk of heat exposure on poor health outcomes in these sensitive groups. So if you have that ability to partner with a medical legal partnership, that can be really helpful as well for kind of expanding how we can serve our patients. So what do we need to do for this child, our 8-year-old with asthma that we talked about when we started? Hopefully your answer to that may have evolved a little bit in this discussion, in this conversation. And these are some of those talking points that we would use to talk through the case with students and residents. What are his exposure risks? How is climate change related to those? What can we do as clinicians? And if we had all the tools that we could wish for, what could we do? And how can we make that possible? How can we get those tools? How can we advocate with our clinician's voice outside of the exam room to make the world a safer place for this child? So why do we do this? Right? We're supposed to be trusted voices. Nurses are always more trusted than doctors, but this map didn't assess nurses. So primary care doctors are over there on the far left. But I really don't think that's it. I don't think it's just that we're trusted voices. I think it also needs to be because in that privileged space of an exam room, we can be trusted listeners. And we're not going to hear those exposures that our patients are facing if we're not asking about them and if we're not listening for them. I love this quotation here. As stewards of community health, we take the pulse of humanity daily and we see the casualties of climate change firsthand. We believe that physicians have the opportunity to change the course of the future. And that's it. Hopefully that was, I know that was a very quick whirlwind overview of what climate change in clinical practice can look like, but I thank you for your attention and welcome any questions that you may have.